what Ozempic is secretly doing to your liver, and why your doctor probably hasn't told you. I am Dr. Daniel, and I need to tell you something that the mainstream conversation around Ozempic has been getting completely wrong. You've heard the success stories. You've seen the before and after photos. You've probably heard someone in your family talking about starting it. Ozempic, semaglutide, has become one of the most prescribed drugs in human history, with over 40 million prescriptions written globally in 2024 alone. But here's what almost no one is talking about. This drug has a profound, complex, and deeply misunderstood relationship with one of the most vital organs in your body, your liver. And it's not simply good or bad. It's both, at the same time, in different people, and the difference between those two outcomes may come down to things that are never checked before you're handed that prescription. Let me walk you through everything, the science, the studies, the cases, the mechanisms, so that by the end of this video, you actually understand what's happening inside you when you take this drug. Part 1. The Miracle. How? Ozempic can heal a sick liver. Let's start with the remarkable side of the story. Your liver is not just a filter, it's a metabolic command center. It regulates blood sugar, processes dietary fat, neutralizes toxins, synthesizes proteins, and produces bile. When your liver becomes overloaded, which is happening at epidemic scale because of modern diets high in refined sugars and processed fats, it starts storing excess fat inside its own cells. This is called hepatic steatosis, more commonly known as fatty liver. What starts as fatty liver can evolve. The fat creates oxidative stress, which triggers inflammation. That's the condition called MASH, metabolic dysfunction-associated steatohepatitis. From there, the inflammation damages hepatocytes, the liver cells themselves, and the body responds by laying down scar tissue. That scar tissue is fibrosis, and when fibrosis advances far enough, you have cirrhosis, irreversible structural damage to the liver, and a direct gateway to liver failure and hepatocellular carcinoma, one of the deadliest cancers. Here's the staggering part. Approximately 38% of adults worldwide have some degree of fatty liver, and most of them have no idea. Now, in August 2025, the FDA approved semaglutide, sold as Wegovy, for the treatment of MASH, specifically for patients with biopsy-confirmed stage 2 or stage 3 fibrosis, and the study behind that approval is genuinely extraordinary. The trial was called the Essence Trial, published in the New England Journal of Medicine. Over 800 patients, all with confirmed MASH, all biopsied before enrollment. They were randomized to either Ozempic or placebo over 72 weeks. The results were striking. 63% of patients on semaglutide achieved complete resolution of liver inflammation, compared to only 34% on placebo. Now I want to pause on that placebo number for a moment, 34%, because that tells us something powerful about the role of belief, behavioral change, and the liver's own regenerative capacity. But that's a topic for another day. On fibrosis specifically, the scar tissue, 37% of patients on semaglutide showed measurable improvement versus 22% on placebo. These are meaningful, clinically significant numbers. In a field where effective treatments for liver fibrosis have historically been almost non-existent, this represented a genuine breakthrough. But here is where the story gets far more interesting and far more important. Part 2. The discovery that changes everything for years. The medical consensus was simple. Ozempic helps the liver because it causes weight loss. You lose weight, fat leaves the liver, inflammation resolves, fibrosis improves. Clean mechanism. Straightforward explanation. Then Daniel Drucker entered the conversation. Dr. Daniel Drucker is not a fringe researcher. He is one of the scientists who literally co-discovered GLP-1, glucagon-like peptide 1, back in the 1980s. He is, in every sense of the word, one of the founding fathers of the entire scientific field that made Ozempic possible. And something was bothering him. In certain patients, liver improvements were happening too fast and at magnitudes too large to be explained by weight loss alone. The math didn't add up, so his team at the Lunenfeld Tannenbaum Research Institute in Toronto designed a very specific experiment. They engineered mice that were genetically modified to be physically incapable of losing weight in response to GLP-1 agonists. These mice could not shed a single gram on the drug. Then they gave them semaglutide anyway. The results, published in April 2026 in Cell Metabolism, were paradigm-shifting. The livers of these weight-loss-resistant mice improved. Inflammation dropped. Fibrosis markers reversed. The hepatic fat content decreased. None of this was mediated by weight loss because there was no weight loss. The explanation: GLP-1 receptors, the same receptors that Ozempic activates in the pancreas and the brain, are present directly in the liver, in hepatic stellate cells, which are the primary cells responsible for fibrosis. In Kupffer cells, the liver's resident immune cells that drive inflammation, and in hepatocytes themselves. Ozempic was speaking directly to the liver, not through the proxy of weight loss, not through improved insulin sensitivity downstream. Directly, through receptors embedded in the liver tissue that the entire field had either overlooked or underestimated. This changes the clinical picture entirely. It means that the liver benefits of semaglutide are not simply a consequence of becoming thinner. They are a pharmacological effect in their own right. It also opens an enormous question, because if the liver has its own direct GLP-1 response pathway, what exactly is that pathway doing in the millions of people taking this drug primarily for weight loss, not liver disease? Part 3. The Other Face. When Ozempic damages the liver. Now, I have to be very careful here and very precise because this is where the nuance becomes clinically critical. There is a documented, real, and underreported risk of hepatotoxicity, liver toxicity, associated with GLP-1 receptor agonists, including semaglutide. Let me give you a concrete example. A 67-year-old woman, no known liver disease, started Ozempic for weight loss following a bariatric surgery evaluation. 2 weeks later, she was in the emergency room. Her ALT level, that's alanine aminotransferase, one of the primary enzymes used to detect liver cell damage, was 1,616 units per liter. For context, normal ALT is under 40. A heavy chronic drinker with cirrhosis might register around 200. Acute acetaminophen overdose, Tylenol poisoning, can reach 1,000 to 3,000. This woman, on Ozempic for 2 weeks, was in that critical range. Her liver was in the process of failing. This is not an isolated case report cherry-picked from the internet. A large-scale pharmacovigilance analysis examining over 106,000 patients found a measurably and statistically significant increased risk of acute liver injury in women taking GLP-1 receptor agonists compared to those taking other diabetes medications. The mechanisms behind this are multiple and interconnected. Let me break each one down. Mechanism 1. The fat flood. When you suppress appetite dramatically and rapidly, which Ozempic does very effectively, your body begins mobilizing stored fat at an accelerated rate. The adipose tissue starts releasing free fatty acids into the bloodstream, and those fatty acids must all be processed by the liver. Here is the problem. The liver has a finite capacity to handle fat oxidation and export. When you flood it with more fat than it can process, that fat accumulates inside hepatocytes. In a healthy liver with full reserve capacity, this is manageable. But in a liver that already has subclinical inflammation, early steatosis, or reduced metabolic flexibility, and remember, 38% of adults have fatty liver they're unaware of, this sudden surge can push the organ over a tipping point. What's particularly counterintuitive is that during aggressive fat mobilization, the liver's fat content may actually increase before it decreases. Studies using MRI-based hepatic fat quantification have confirmed this paradoxical initial increase in hepatic steatosis in some patients during the early weeks of GLP-1 therapy. Mechanism 2. The gallbladder failure. Your gallbladder sits directly beneath your liver, connected by the common bile duct. Its job is to concentrate and release bile, a fluid manufactured by the liver that emulsifies fat, aids digestion, and serves as a clearance route for excess cholesterol and metabolic waste products. GLP-1 receptors are present in the gallbladder smooth muscle. When those receptors are continuously activated by semaglutide, which, unlike the natural GLP-1 your gut produces that lasts only about 90 seconds, stays active in your body for 7 days, the gallbladder loses its normal rhythmic contractility. It stops squeezing bile out properly. Bile becomes stagnant. Stagnant bile leads to biliary sludge. Biliary sludge leads to gallstones, and gallstones can obstruct the bile duct, causing bile to back up into the liver, creating a form of cholestatic liver injury that can be severe and rapid in onset. This is not theoretical. In 2023, the FDA required Novo Nordisk, the manufacturer of Ozempic and Wegovy, to add a black box warning about acute gallbladder disease to the prescription label. Clinical trial data showed that semaglutide users had a significantly higher incidence of cholelithiasis, gallstone formation, and cholecystitis, gallbladder inflammation, compared to placebo. A 2023 meta-analysis published in Diabetes, Obesity, and Metabolism, aggregating data from over 76,000 patients across multiple GLP-1 trials, confirmed a 27% increased relative risk of gallstone events among GLP-1 agonist users. Mechanism 3. The monitoring gap. Here is perhaps the most troubling part of this entire picture. Hepatotoxicity is not listed as a warning on the Ozempic label, which means that in standard clinical practice, liver enzymes are almost never checked before a patient starts the drug, and almost never monitored in the weeks that follow unless the patient presents with symptoms. The symptoms of early drug-induced liver injury are nonspecific: fatigue, mild right-sided abdominal discomfort, reduced appetite, nausea. These are also among the most commonly reported side effects of Ozempic itself. So when a patient reports these symptoms, the default response is, "That's normal for the drug," not "Let's check your liver panel." The result is that mild to moderate hepatic injury is systematically missed, attributed to expected gastrointestinal side effects, and only identified when patients deteriorate enough to seek emergency care. Part 4. The population-level mismatch. The FDA approval for semaglutide's liver benefits is highly specific. Biopsy-confirmed Stage 2 or Stage 3 MASH under medical supervision, with gradual dose titration and close laboratory monitoring. Approximately 1 in 20 people currently taking Ozempic fits that profile. The remaining 95% are taking it primarily for weight loss. Many are started at therapeutic doses without gradual titration. Most are not having their liver enzymes monitored. A substantial proportion, given that 38% of adults have subclinical fatty liver, are taking a drug with direct hepatic receptor activity while having a pre-existing hepatic vulnerability that was never screened for. This is the population-level mismatch at the center of the Ozempic liver story. The same drug, in highly controlled trial conditions in the right patient population, produces healing. In an unscreened general population with limited monitoring, it produces a spectrum of outcomes ranging from the same healing, to nothing, to acute liver injury. The drug is not inherently dangerous, but the conditions under which it is being broadly prescribed are creating a situation where its hepatic risks are systematically invisible. Part 5. The long-term picture. What happens when you stop? One thing that rarely gets discussed in the excitement around Ozempic's results is the trajectory after discontinuation. A landmark follow-up study published in the journal Diabetes, Obesity, and Metabolism tracked patients 1 year after they stopped semaglutide. The findings were sobering. On average, patients regained approximately 2/3 of all the weight they had lost. Blood sugar improvements reversed substantially. Cardiovascular risk markers returned toward baseline. Even more concerning from a metabolic standpoint, a body composition analysis revealed that between 25% and 40% of the weight lost on GLP-1 drugs came not from fat, but from lean tissue, specifically muscle mass and bone density. This matters enormously for long-term metabolic health, because skeletal muscle is the primary tissue responsible for glucose uptake, and bone density loss increases fracture risk in older adults. When weight is regained after drug discontinuation, it tends to return disproportionately as fat rather than lean tissue. This means the post-Ozempic metabolic state can, in some cases, be worse than the pre-treatment baseline in terms of body composition. And for the liver specifically, a metabolically compromised liver with insulin resistance at its root is not addressed by the drug. Semaglutide manages the downstream consequences of impaired GLP-1 signaling and insulin resistance, but it does not correct the underlying dysregulation. When the drug is removed, that dysregulation reasserts itself. Part 6. What you actually need to do if you're on Ozempic. This is not a video telling you to stop your medication. If you are taking Ozempic under medical supervision for diabetes, for confirmed MASH, or for cardiovascular risk reduction, those are evidence-based indications with solid data behind them. Continue working with your physician. But there are things you should specifically ask for and do, regardless of why you're taking it. First, get your liver enzymes checked before you start, and again at 4 and 12 weeks. Ask for an ALT, AST, GGT, and alkaline phosphatase panel. This is a simple, inexpensive blood test. If your doctor doesn't order it proactively, ask for it. If you've already been on the drug for months without this check, ask for it now. The presence of baseline liver vulnerability changes the risk calculation entirely. Second, if you develop fatigue, right upper quadrant discomfort, darker urine, or yellowing of the eyes, these are signs of potential hepatic or biliary injury. Do not attribute them to routine GI side effects without a liver panel ruling that out. Third, prioritize dietary protein. Semaglutide suppresses appetite broadly, and many patients inadvertently underconsume protein while on it. Skeletal muscle is metabolically expensive. Your body will catabolize it if protein intake is insufficient. Aim for adequate animal protein or high-quality plant-based sources at every meal. This is not optional if you care about body composition outcomes. Fourth, resistance training is non-negotiable. It is the primary pharmacological-grade intervention for preserving lean mass during caloric restriction. It also directly improves hepatic insulin sensitivity through GLUT for translocation and mitochondrial biogenesis pathways in muscle tissue. The liver benefits of resistance training are independent of and additive to any drug. Fifth, reduce refined carbohydrates. Ozempic does not correct insulin resistance. You must do that through diet. Chronically elevated insulin is a direct hepatic lipogenesis driver. It instructs the liver to manufacture and store fat. No drug fully compensates for a high refined carbohydrate dietary pattern. Reducing carbohydrate load, particularly from ultra-processed foods and liquid sugars, is the only dietary intervention with consistent evidence for reducing hepatic fat content. Sixth, support bile flow. This matters given the gallbladder mechanism. Adequate dietary fat intake, paradoxically, is necessary for normal gallbladder contraction. Extremely low-fat diets actually increase gallstone risk because they further reduce the stimulus for gallbladder emptying. Healthy fat sources: olive oil, fatty fish, avocado, maintain normal biliary kinetics. Closing. The Ozempic story is not a simple story. It is a story of a genuinely powerful pharmacological compound that acts through mechanisms the scientific community is still in the process of fully mapping. A drug that can heal scar tissue in a diseased liver and produce catastrophic liver failure in a healthy one. A molecule that binds to receptors in the brain, the pancreas, the gut, and, as we now know beyond doubt, directly in the hepatic tissue itself. The question is never really whether the drug works. The data on that is extensive. The question is whether the conditions under which 40 million people are taking it reflect that complexity, and whether the monitoring systems around it are adequate to catch the people for whom it is doing harm rather than good. That is a question worth asking your doctor, and if they don't have a ready answer, it is worth asking again. I am Dr. Daniel. Stay informed.